So please come in, take a seat. My name is Corrie van der Sluis. I'm the chair of the Scientific Program Committee, and I welcome you all to this keynote speaker session. And it's a great honor for me to introduce the first keynote speaker of this I.S.P.O conference today. As you know, the theme of this 20th World Congress is Science in Practice, Practice in Science, Collaboration and Innovation towards Sustainable Rehabilitation. All parts of this theme are applicable to the keynote speaker of today, Mr. Chapal Khasnabis. For years, Chapal has done important work at WHO, where he connected science to practice by composing guidelines and standards related to assistive technology. As prosthetist and orthotist by training, he incorporated his practical knowledge into science by founding Mobility India, by leading WHO's GATE initiative, and by facilitating the formation of the Global Partnership for Assistive Technology, also known as AT-Scale. In that light, it is an interesting saying of Chapal that assistive technology is the new medicine of the 21st century. Collaboration with other sectors, such as industry, is the focus of his current job as Senior Advisor for Assistive Care and Technology at the Asian Development Bank. Finally, sustainability has been a focus of Chapal's attention, as we can read in his scientific publications. Therefore, Chapal is the person to explain to all of you how important collaboration and innovation in P&O are towards sustainable rehabilitation and beyond. Mr. Khasnabis, I would like to invite you to the floor.
Thank you, Corey, and good morning, everyone. It's a real honor and pleasure to talk in front of all of you, my great friends. And I have been told to talk about prosthetic orthotic science is the key of sustainable rehabilitation and beyond. But with your permission and sincere apology, I'll also talk a little bit about my long journey so you can understand how the prosthetic orthotics has changed the world to a great extent. And I especially thanks to I.S.P.O, because when I came to the international world from the small national developing country, a small project, it slowly started opening my doors, one after other. It started influencing my lateral thinking. And really, in this whole journey, I met a lot of great people, from John Hughes, Steen, Ceci Sawamura, Forchheimer, and of course, Claude, David, and all this, Jan, Dan, so many friends I have in this long journey. But one thing I realized, to be part of this movement, of this I.S.P.O, was my school days dream. The day I graduated, I said I should become a member of I.S.P.O. And whenever I started my active life in Mobility India and all, first thing I did, partnering with I.S.P.O. So today's my talk will be little beyond rehabilitation. 13 years ago, when I said we should talk about assistive technology, in WHO, including my director, said, what is assistive technology? So nobody understood from where I'm coming, why I'm talking. And now I'm talking assistive care. Why I'm talking assistive care? If you do not realize now, mark the date, you will realize after 10, 20 years that what I'm talking, how relevant, how important it is. So let's look back a bit. The history of rehabilitation starts mostly with the World War I, II, and the polio. The major drivers, three major drivers of the rehabilitation were this, besides some blindness and deafness. But we are no more in that period, though there is some war going on every day, but not the same experience like World War II or I, or don't have a disease like polio, which makes millions of people disabled for life. So my journey, I started in 1979, and what I saw, only polio. Polio, 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 everywhere. Ritu and Shoikat are here. We used to see 200, 300 children a day, polio. And we could not have followed the protocol, this clinical muscle testing, evaluation, no. We are very innovative. We had to take, at the most we could afford 3 to 5 minutes per child. So in these 3 to 5 minutes, I have to decide whether this child will be benefited through KFO or AFO. So developed a simple test, 1 minute, to decide whether KFO or AFO. May not be 100% perfect, but it made 95% children to walk on their legs. So 1994, seeing the need, created Mobility India to address the people's problem. And the best thing what we did in Mobility India, we never waited people to come to the center. We went to the people. We never expected people to come. They cannot come. Poor people with the disabled child, family members, they cannot come to the big cities, and it's expensive. Sometimes travel is more expensive than the treatment. So we decided, why don't we go and reach there? And we also developed different orthoses, plastic orthoses, $25 to $50, all Jugaad innovation, all local innovation. The necessity actually threw us in this journey. So in 2002, Mobility India Rehabilitation Training Center we established. And I was very proud when Ritu yesterday presented new ancient lecture. So Ritu is one of my favorites, also Soikat, and also Shubhas. Many people went out of Mobility India, and there are stars everywhere. And thank you then I.S.P.O. and Claude, and offering me the categorization, I.S.P.O. recognition, the first school, or maybe the only school in India which has the I.S.P.O. categorization. So all the students get that certificate. So as Ritu said most about Mobility India and what they do in her presentation, so I'll focus more on what I did in WHO. So in 2003, I moved from Mobility India straight to WHO. And what a mistake I did in my life. So I was completely at loss. Somebody said it's better to be number 1 of the hell than number 2 of the heaven. So I said, oh gosh, where I am. But fortunately, I had a good boss. And I was familiar with Ortholator and WHOs quite a bit. So when I came to WHO, I was trying to figure out where we exist. In the hierarchy, the bottommost is the prosthetics and orthotics. And my best friend from Sweden, one of my best friends, he lost the job because he was only doing prosthetics and orthotics. So my boss told me, you cannot survive in WHO only doing prosthetics and orthotics. You have to take care of all others. So it was really tough for me to see how the prosthetics and orthotics fit in public health, Ministry of Health, and WHO. WHO is the mother of Ministry of Health of all world, right? So It was very tough for me to understand, but at the same time, I'm ever grateful to WHO, like I.S.P.O. It helped me to open my eyes, to expand my knowledge, to meet different people, different experts, organize different meetings. It took me more than, I think I know the prosthetic orthotics provision of more than 50 countries. It took me to 100 countries to travel, understand, meet people, what it is, how to do it, and did some big meetings like I.S.P.O, WHO Consensus Conference on Wheelchairs. The enemies started talking to each other. They were not talking in terms, but we brought them together. And sometimes it was so horrible experience. Some people are sitting on the floor. We thought anytime meeting will be destroyed, but we managed to keep it together. So it was a lot of experience. And then I started stretching WHO, because I realized if I keep only focus on prosthetics and orthotics, I lose the job very soon like Anders did. So I have to expand. And then so stretch slowly prosthetic, orthotics, wheelchair, and then assistive devices, and did a lot of job which I really proud of, and I'm sure many here are proud of, especially I.S.P.O. and WHO partnership is something phenomenal. So what I did, I was trying to develop the profile of assistive technology in the world. Because if you know the subject, but if you don't have the support, you'll never be able to sell it. So I was trying to do, and one of the biggest, if you know the workshop of the world of assistive devices is China. So went to China several times and tried to understand how it works, got them engaged, involved, and that actually started game-changing. I'm sure you know this German chancellor talking with Chinese prime minister. Unfortunately, he died a few months ago. And they were talking about how technology transfer and how can China become a global player in the assistive technology world. I also learned from many countries. Sweden and Norway, my favorite countries. I used to come again and again to learn how they do prosthetic orthotics provision in these countries. I met a lot of people, and one of those program of NAV in Norway impressed me quite a lot. Because in Norway, what I learned, everybody has a right to have a quality assistive product. And they have one database, no competitor. One database, one system, and from the city to the local municipality, people have the same quality of service, same waiting period. So we realized in Norway, 75% AT users are 60 plus. Not all are disabled. Maybe they have a functional decline, they have an impairment, but 75% are 60 plus. And on average, people use 3 assistive products. It's not 1, 3. So, as I said, I used to come to Sweden often. How many of you heard Hans? If you hear him once, you'll never forget him, right? And that's his pointer on his hand. And he is one of the great leaders in the public health. So I used to ask Hans, how can I make this prosthetic orthotics, this assistive device, these issues of disability higher in the agenda? He said, keep it simple and practical messaging. He used to compare all the facilities, hospital with his bedroom, bathroom, and he has his own way of selling the message. And second thing he said, focus on data. You need data. Without data, you cannot convince anyone. And data means number. If some 1,000 people gets benefit, forget it, nobody will care about you. Even 1 million in some countries will not make any difference. He also said, make it as a public health priority. You should say that without this, what disaster can happen in the public health? Then only people will listen to you. He also said, make a return on investment, because every Ministry of Health are struggling with the funding. There are competing agendas, and you have to ensure in that competing agendas, your agenda survives. And he also said, make a World Health Assembly resolution. These are the 5 mantras he gave me to take the assistive technology or prosthetic orthotics to a new height. So what I did, I started working on the data and the number. World is aging fast. There's a demographic change. And this change is happening faster than the resources we have. Without our any intervention, world is aging. And if you see compared between 20th century and 21st century, the most health conditions of 20th century was unimorbidity. Mostly polio, amputee, spinal cord injury, mostly unimorbidity. But in 21st century is more comorbidity or multimorbidity. Take example of diabetes. If you have a diabetes, you don't have only amputation, you could also have a hearing loss, vision loss. So as we grow older, now I'm not talking about others. I'm talking about us, about me, my family. That as we grow older, I'm seeing how the gradual functional decline is happening in my own family. I saw my mother. I saw my father. So as you grow more, sometimes some people said dying early is better, which I do not agree. I really love to live as long as possible and experience all this, and it helps me to understand. So maybe we start with the glasses. Many of here are using glasses or contact lenses. But as we grow older, we'll go for stick, crutches, and ultimately when we cross 80 or 90, we all will have a wheelchair. That's the last assistive product we can think of in our life. So it's not, and you cannot rehabilitate these people. You have to go with them until their last breath. And that's what I said, assist. You need to assist people to live a quality of life, to be productive, to prevent them from falls and all. So aging and gradual functional decline goes hand in hand, made for each other. Whatever you do, you cannot reverse it. It will happen. So this is one study in India they have done called LASSI, aging study, aging and connecting the disability. And they have found nearly 38% people have at least one disability, 60 plus, or functional decline or impairment. 15.4 has 2, and 5 has 3. So it reinforces as you age more and more, your more functional domains will be affected. And it also said that 20% have some kind of a mental or neurological disease, either from excluding headaches. And 43% used at least one assistive product, maybe stick, maybe crutch. It's one of the biggest study in India, and they found this. So when I come to WHO and I said, look, a few years ago we have done a 50 years of Alma Ata, review of Alma Ata. and tried my best to convince WHO to think beyond the traditional definition of healthcare: preventive, promotive, curative, rehabilitative. I said this definition came in 1978, where the life expectancy was 62. This cannot fit in the 2025, where life expectancy is 74. So then I said, look, we have to have the 21st century healthcare definition should be preventive, promotive, curative, rehabilitative, assistive, and palliative. Whatever happens with your health condition, due to the medical advancement, from rehabilitative to palliative, you'll have 20, 30 years in between life. And that time, you might need some kind of a support, short-term, long-term, intermediate, so this. And that's where the support comes in the form of assistive care. And assistive care will become a buzzword, if not today, 10 years down the line. So assistive care and assistive technology, many people tell me the prosthetic orthotics under rehabilitation. It's not. We have the role in each part of the healthcare, in the preventive, promotive, curative, rehabilitative, assistive, and palliative. Everywhere we have the role. And when we can establish this role, you have the number, you have the market, and you can convince the Ministry of Health why your area should be a priority. So what I did in WHO, I said, keeping these assistive products under rehabilitation is not making us any good. Tier 8. So I said, look, make it as a public health product. I said, we need medicines, we need vaccines, we need diagnostics, we need assistive devices. So shifted the whole, and everybody needs. I didn't say it's only for disability. If it was only for disability, I would have stuck there. I said it's a public health product. It's a health good I'm talking about. It's a fourth dimension of the health products. So move the whole assistive products to under the essential medicines and health products department. We got 4-level jump. So now we are much above than what we were before, because we have been recognized as a health product group who is as important as medicines and diagnostics. So when we moved to that, we started talking also with the health language. We said 6 building blocks of health system strengthening. From there, we made a framework, and we said that 80 should be available from the grassroots primary health care up to the tertiary care. So, but you need support. I cannot, even if I shout, nothing will happen, okay? So lot of people we invited, and on 4th July 2014, established the GATE initiative, Global Cooperation of Assistive Technology. Some of you attended that meeting. Many people asked me why? Why ATU? Why doing? But you know why today. So if you are in the public health, if you have done the medicine, there is one driver which changed the public health. That is the essential medicines list. Almost 90% countries in the world has an essential medicines list. All your reimbursement of medical treatment depends on your medicine, whether it's in essential medicines list or not. So I said to them, okay, why can't we have an essential assistive products list then? Make a list of essential assistive products in the line of essential medicines. And in that, Everybody told me, no. We are vision, we are separate. We are hearing, we are separate. We are mobility, we are separate. Prosthetic, everybody is saying that we have a different standard of protocol. We have a different policy, different system. So I told them, okay, gave them a chart. My friend, Rob, he's a neutral, he was a funder, nobody could challenge him much. So I said, okay, ask them to write what is the difference from other. Half an hour, nobody could write what way they're different than other sector. Everybody needs a patient, everybody needs an assessment, everybody needs a product, everybody needs solution, service. So they could not write. And that gave me the leverage to develop first assistive products list. And now many countries are developing assistive products list. And I hope that more and more countries will follow the same. From there, we went to the World Health Assembly. First time in WHO's history of 65 years, there's a resolution on assistive technology. Thank you to many of you supported us to do that, but that changed the whole game. Now any ministry, before anything you talk about this, go to the Minister of Social Welfare. It's a charity, it's a care. Go there. But when I go with the resolution, I said, your government, your minister signed it. You cannot deny your own product. Then the door opens. And of course, piano quality, piano was our starting point, so we always focused on that. And this assessment guide, many of you standards, in the standards, many of you have not noticed the sentence I used there. Nobody was treated as a health professional before. I written very in bold that we are health professionals, allied health professionals. So this is the first time I think WHO document you have that recognition. Then assessment guide. And I sincerely request all of you, make use of this guide, assessment guide. In one day, we'll know where you are and what you need to do to upgrade your services. It's a very good tool developed by WHO with help of I.S.P.O. Make use of it. If you do not know where you are, you'll never be able to know where you have to go. So last, I did this world report. Tedros, the DG, said this is the first time in WHO's history there's a global report came on assistive technology. The minister, she was so impressed with this whole process, gave a lot of money to us. And British foreign minister was launching the same in her own country. There are a lot of data in it. And if anything, you have a question, ask Yuan. He was the man behind all this data. Also why? So we came with this data that 2.5 billion people need assistive products now with glasses, and 3.5 billion by 2050. And 0.9 billion, nearly 1 billion people now, and 1.3 by 2050 need assistive products. Now we have the number. Now we can talk to the ministry. This is the number. You cannot ignore this number. But it also says this is the market. If you have to talk on the market, how much the potential this business is. And we also see that 2 out of every 3, about 60, needs at least one assistive products. As we said that these also helped me to do better campaigning. So in the first Global 80 Summit, we put the 80 as an agenda, priority agenda, and got a lot of money for this. And 2 organizations came out from that first summit. One is 80 scale, and another is 80-20-30. Nobody believed me when I started this. So every story has an ending. Every book has an end. So 31st January 2023, suddenly from staff to retired, they gave me a new badge. And I said, bye-bye. And my chapter with WHO nearly got over on the 31st January. But my passion continues. My belief continues. So assistive care and assistive technology. And if you look at this slide, every person has an assistive product and has a human person to support. So no assistive product can replace the total human care or human support. So it has to go hand in hand. And fortunately, there is always some people to support me. So I said, so I go to the people. Most of my knowledge is from the people. Now I go to the old villagers, sit with them, listen to them, and try to solve their problem. I follow the 5P framework. So the policy, I talk about assistive products should be within health insurance. Why assistive product should be a charity? Why it should not be part of the health insurance in most countries? In Geneva, my glasses are provided by health insurance. Any devices I need, they're provided by health insurance. But that doesn't happen in most part of the world. And as it doesn't happen, the sector is not growing. Whatever you do, whatever you develop, unless and until you really influence these big tickets in the policy, things will not change. Do not know colleagues from Egypt are here or not, but we put this in the agenda of the president of Egypt. And he organized a meeting. So when president calls a meeting, obviously it gets a higher profile. So we talk about products and products beyond the traditional products, okay? All kind of products, from a simple stick to a very advanced digital robots. And also, there is another new group has come, is the caregiver. We neglected the caregiver's role. We neglected the caregiver also becomes disabled, taking care of the older people. So caregiver needs a lot of support to ensure they give a proper service to an older person. And this brace, who is making? Can you guess? Toyota company. So the car companies are now getting more and more interested in this sector. So in future, there will be more products from the mainstream automobile and technology industry in our field, from Google to this Toyota or Hyundai. Keep an eye on this. Now, personal, beyond prosthetics and orthotics rehabilitation. The need is so huge. We prosthetic orthotics or even our partners, OT, PTs, ATs, cannot solve it. We have to go beyond. And one is this health workers, field workers, social workers, the people who are going door to door in people's house. They know which older person needs what, and make use of them. Use them to give the simple assistive products. Vision sector has realized this. They use the local health workers to provide the reading glasses. If they can do that, why can't we give the stick or crutches through them? Why they need as qualified category 1, 2, BPO, MPO professionals to give a stick? I just don't understand. And the provision. And provision also, it should be 3-level. This is a little bit I copied from, again, Norway. The simple products should be given by the generalist from the simple at the grassroots level. And as the complexity of product goes up, you come up to tertiary level. This is the place where I go to get my glasses. 20 years I'm going there. Since last 2-3 years, I'm seeing they're also expanding from vision to hearing. Because many people going there for the glasses, they also need hearing aid. So they saw the new market. So they already opened it. I also facilitate still a lot of international collaboration. Sir Claude. Claude and I was with the president of Egypt and was really trying to see that how we can put our agenda. And then the Egyptian team we brought to the government of India, ministry level, and trying to see that whether India and Egypt can sign a treaty to help each other to develop these products. Thank you.
Thank you, Chapal, for a very impressive talk and also impressive work you have done for not only the P&O sector, but the entire assistive technology sector. I would like to open the floor for some questions you might have for Chapal. And if you do so, please use the mics that are in the hallway here in front of you. Is there anyone who would like to ask something? If not, I would like to ask you something, Chapal, because you have talked about the bigger picture, but what would be your primary advice for I.S.P.O to work on for the next 2 years or maybe the next 5 years?
I always believe that I.S.P.O should offer twin-track approach. On one hand, strengthen the prosthetic orthotic sector, but at the same time, help the other sector, because we are interconnected. Many people who need prosthesis, orthosis, they will need other devices, because we are not in those polio early days. Now it's more conditions, more clients will be elderly people. And elderly people will not have only prosthetics or orthotics problem. They will have other problem issues. So I believe that as the I.S.P.O is a very well-structured, well-experienced organization, they should play a larger big father or grandfather's role to bring the whole picture in front of people and work together to ensure that we are really taking care of the people's need, not only some professionals' need.
So would you suggest to change the name into ISAT instead of I.S.P.O?
No. Because changing name creates a lot of issues and all this, but what I said, look, change is inevitable, but it doesn't mean that you have to change the name all the time,
okay.
But you have to change the approach and the strategy and expand. I'm the same prosthetist orthotist. That's my qualification, right? But you see over the year I changed and diversified so much.
We should have an open mind.
It's open mind, that's true.
Well, this brings us to an end of this wonderful keynote lecture. So I would like to thank Chapal. So please have an applause. And I have a small gift for you, which is a Swedish horse, as to remind you of this keynote lecture. Thank you very much.
Thank you.
And I will now give the word to David Constantine for the next session, which is about a nice prize. Should I stay?
Yeah.
Okay.
Yeah. Is that on? Hello. If you could all sit down for a moment. Can we hold your attention just for a few more minutes, please? Because we have something very important in the I.S.P.O calendar to do, and then you can have a coffee or even a cigarette. Each year, on the year of the Congress, not consensus, we award several prizes from I.S.P.O. And today we are going to be presenting the Forchheimer Prize. And this is in memory of the Sylvia and Alfred Forchheimer family. And we're very lucky because we are in Sweden and the family are from Sweden. that we have members of the family from several generations with us here today. And Robert Forchheimer, the son of Alfred and Sylvia, and his daughter Suzanne, are going to come up and present the prize. And this is for the best team of the best authors of a paper that goes into POI, Prosthetics and Orthotics International, the peer-reviewed paper, the journal that you get with your membership free of charge if you're an I.S.P.O member. And for the last 2 years, all the papers have been passed, published, and the best one is voted on by our scientific committee. And the prize winners will come up and receive the prize from Robert and Susanna. So could I invite you up, Robert and Susanna? And I'd just like to say that the whole prize is very much a family affair. So we have here Robert, the first generation from Sylvia and Alfred, but the whole family is involved in this, which is wonderful.
Not only that, since we have been involved in this since many years, first time in Japan, I believe, in 1989, it's time to hand over to the new generation. So I'm proud to bring my youngest daughter to the microphone. Please.
Thank you. Thank you so much. Good morning, everyone. My name is Suzanne Forchheimer. I'm the youngest granddaughter of Fred and Sylvia Forchheimer, and I'm very excited to be with you all here today to present the Forchheimer Prize, especially here in Stockholm with the rest of my family. So I would like to bring up this year's winners, and I have the diploma for you all. So it's on behalf of the Forchheimer Foundation and the family, this year's prize goes to, and I might butcher the name, but Burroughs Fard and his co-authors.
Would you like to say something? You don't have to.
I appreciate it if I do it at the end. So how do I control the slides? Thank you. So, 10 minutes I got and 10 minutes I will use. Oh. Hello, my name is Burroughs Fard. I'm a rehabilitation physician working for Roesing Center for Rehabilitation in Enschede, the Netherlands. First, a conflict of interest disclosure. This guideline was commissioned and financed by the Dutch Association for Medical Specialists. The contents of this presentation will be an outline of the article, focusing on what medical guidelines are in the Netherlands, development process of the guideline, and a quick view of 2 key questions and recommendations. The article itself was published in Prosthetics and Orthotics International. It was a translation and summary of a much more extensive guideline, the 2020 Dutch Multidisciplinary Guideline. Whereas the guideline was about 162 pages, the article was 25 pages. The guideline was much more extensive, presented the systematic reviews, detailed results, conclusions, and the recommendations, and it was put up as such that it could be reproduced in the future and to provide a room for additional key questions. The article itself focused on presenting the methodology and development process and presenting the core of the conclusions and recommendations. The goal of medical guidelines is to improve the standard of care in the Netherlands, but it is a serious matter. Disciplinary boards do expect you as a specialist to adhere to guidelines, and if there is a recommendation, it ought to be followed. There is room for deviating from guidelines and recommendations, but you have to justify and document your reasoning in the patient's records. Language determines the strength of recommendations. There are strong recommendations and weaker ones. To give you an example from the most current neurology guideline for carpal tunnel syndrome, we can read that nerve ultrasound is to be preferred compared to EMG when available. So it's a strong recommendation. However, consider steroid injections for carpal tunnel. So this leaves room for the discretion of the neurologist. Subsequently, a must-do condition, do evaluate after 6 to 12 weeks. This might seem a bit of a semantic discussion, but it's very important, and we will touch upon it further on in this presentation. The development process, I hope you trust us. We ask for input from all organizations and associations involved in the multidisciplinary care for persons with an amputation, and they were asked to provide input and representatives, and this led to formulating 12 key questions. The work group consisted of 15 healthcare professionals, the experts. You can read them, everyone was represented, and a scientific staff from the Dutch Association of Medical Specialists, whose primary job is to develop guidelines. These are people who are working concurrently on 3 to 4 guidelines each year. And I cannot stress out how effective it was to have such a dedicated and experienced scientific staff to support us in this endeavor. To give you a quick view of the process from start to finish, we started off in the work group by exploring the topics. With the help of the stakeholders, all the organizations involved, we formulated 12 key questions. Then, with the help of the scientific staff, literature search, article selection, review and summary of the literature, assessment of the conclusions, and then, within the work group, considerations leading up to preliminary recommendations, which were put forward to the stakeholders, and eventually the definitive recommendations were authorized by all parties. Please don't try to read them all. These are the 12 questions. You could imagine my panic when asked to present the guideline in 10 minutes. It's impossible, so do forgive me. We can only focus on 2 key questions for today. Literature search. Eventually, we performed 10 systematic searches in one project for the guideline. We started off with about 4,000 studies identified, and by process of elimination in the flowchart, leading up to 59 studies being included. The assessment of the level of evidence was performed according to the GRADE system or guideline, which is widely used for all medical guidelines in the Netherlands, which leads to a grading of a certain conclusion ranging from very low to low, moderate, and high level of certainty. The considerations, and this is very important to realize, the evidence-based conclusions are important but do not dictate their recommendations. We were given room to provide additional literature not identified in the systematic reviews, and we had to weigh the evidence against the consequences of certain recommendations in clinical practice. Also, we had to be very clear about the boundaries between expert opinion within the work group versus the actual evidence as presented. Well, we're in Sweden, we cannot ignore osseointegration, so the first key question to be presented is this one. Unfortunately, no studies were included, and that is because the GRADE system only allows for trials, preferably randomized and blinded, for these types of questions. And regardless of my personal or professional opinion, the conclusion was as follows. It remains unclear whether osseointegration versus prosthetic sockets is comparable, better or worse in terms of gait parameters, patient satisfaction, mobility, or energy consumption. However, we could not ignore the many observational data ranging from the 1990s up till now, and we could also not ignore that the practice of osseointegration is no longer a fringe and experimental procedure. So we came up with this recommendation, which is not a very strongly formulated one, which states, consider osseointegration only for persons with non-vascular limb amputation whose use of prosthesis is limited or prosthetic components have been ineffective. The next key question, our mission set up by the stakeholders was provide us with a set of instruments to be used for clinical practice. For this key question, we were able to identify many studies. 15 studies were included, analyzing 12 different measurement instruments. We focused on the constructs ambulation and mobility, and assess the validity, reliability, and responsiveness of said instruments. The grade levels were low to moderate, which isn't that bad for within our field. And we were able to provide what's somewhat a stronger recommendation, meaning do use the L test, 6-minute walking test, AMP Pro, and a CGAM-WAP scale as a set of instruments for persons with lower limb amputation. And subsequently, a softer recommendation, consider the +M or walking questionnaire for insights into self-reported levels of amputation and mobility. A word of thanks. I am very, very honored to be considered representing all authors for the Forchheimer Prize. I would like to very much thank the Forchheimer Foundation and family for this incredible recognition. Thank you. 1 minute, I'm not done. Then you can go to your coffees. I would like to thank the I.S.P.O, Scientific Committee, World and Local Organizing Committee, and all the supporting staff. And of course, Prosthetics and Orthotics International, the Federation of Medical Specialists. Of course, this was a team effort with many of the authors being present, but I could not ignore this gentleman sitting in the front, Professor Jan Geertsen, whose relentless and very much hands-on approach from start to finish made this guideline the success that it is today, in my honest opinion. Thank you. And Leslie, and then you can... 15 seconds. Keep up. And of course, I'm here standing up, and I do feel reluctance for the acknowledgement, but I would like to thank the many, many authors that were included in the guideline. They were doing the heavy lifting, and please do keep up the good work. And I would like to thank you, the audience, for your time and attention. Thank you.